Welcome, everyone, and thanks for joining the webinar today. I'm Ken Steele, and I'm pleased to be your moderator for today's webinar entitled Bundled Payments in the Commercial Market, What You Need to Do to Be Prepared. Before we begin the formal presentation, let's review a few details about the webinar. The webinar is 60 minutes in length. The first 45 minutes of the program is a presentation, followed by a 10-minute question and answer session. Everyone should have received a copy of the session handout, but if you were a late registrant, you can download the handout in the handout pane on your screen. Note that attendees are participating in listen-only mode, but if you have questions, and we'd certainly encourage you to ask questions, you can type them into the question pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, we will answer as many of your questions as possible. Finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Our speakers today include myself, Ken Steele. I'm a principal in the San Francisco office. I am joined by two of my colleagues, Purvi Bhatt. Purvi is a senior manager in our DC office, and also Rachel Bidgood. Rachel is a manager in our DC office also. Our bundled payment team at ECG has broad national experience, privileged to serve multiple clients across the country. Our experience includes all types of bundled payments, including commercial, BPCI advanced, and comprehensive care for joint replacement, also known as CJR. We have supported health systems, hospitals, and physician groups in their planning, implementation, and management of these programs. Today, we're excited to discuss commercial bundled payments. As many of you are aware, bundled payments are becoming a more common and crucial component of the payer, employer, and provider strategy as organizations transition to value-based care. Today, we'll review the organizational competencies, capabilities, resources required to successfully develop, implement, and manage a bundled payment program with commercial payers. We will also share our national experience regarding clients who are either planning, implementing, or managing bundled payments. We've designed the presentation to help you better understand your readiness for commercial bundles, along with answering some strategic questions. And today we'll start with Rachel Bidgood, and Rachel is going to be talking about emerging trends. Rachel?
Thank you, Ken. Good afternoon. This is Rachel. Starting on slide 6, there are many reasons an organization, whether that be a hospital, ambulatory surgery center, or physician group, may want to participate under a bundled payment. These reasons may include gaining market share by being first to market, obtaining value-based care experience with defined and limited risk, aligning physicians and other providers, managing the continuum of care, improving patient outcomes, and enhancing the payer-provider relationship. Organizations that embrace value-based payment and proactively seek arrangements with payers or employers can obtain geographic exclusivity and define the parameters of the bundle. Unlike accountable care programs where organizations must manage thousands of lives with limited upside, under bundled payments, organizations manage care for a defined patient population, allowing them to gain competencies to truly manage the risk associated with the arrangement. Lastly, bundled payments can enhance the payer-provider relationship. To have a successful program, both the payer and provider need to become partners. There needs to be a degree of transparency when it comes to sharing data that's used to make the program successful. Moving to slide 7. Over the past year, bundled payment program announcements have become increasingly common. Following the trend of government payers, commercial health plans and employers have also embraced bundled payments. Since 2009, the Centers for Medicare and Medicaid Services has been committed to testing and refining bundled payment models. Currently, CMS is conducting 3 nationwide programs with nearly 2,000 participants, and HHS leadership has indicated that mandatory bundles are coming in the near future, likely in cardiac and radiation oncology. Commercial payers have followed the government's lead, but have been a bit slower with widespread adoption. It's estimated that about 20% of commercial payer business is currently aligned with capped payment models, such as bundled payments, case rates, and MSDRGs. Whereas the government is increasingly interested in bundled payments for medical and chronic conditions, commercial payers have focused more on episodic conditions such as joint replacement and spinal fusion. Blue Cross, Blue Shield, and United Healthcare are market leaders with more mature bundled payment offerings, and we've been seeing additional bundled payment penetration in the Medicare Advantage market. Major companies are also embracing bundles. High-profile articles in Harvard Business Review have outlined the success large companies like Walmart, Lowe's, and Boeing have had with bundled payments. The proven cost savings, predictable cost, and improved quality have many employers flocking to these center of excellence models for frequent employee conditions like back pain and bariatric surgery. On slide 8, we've outlined market pressures that are encouraging the growth of bundled payments. Unsurprisingly, payers have become more price sensitive. Therefore, it's crucial providers understand their true costs and reduce spending or utilization where necessary, given the enhanced scrutiny from payers. As previously mentioned, payers continue to launch and expand bundle payment programs. There has been demonstrated success, and early adopters have gained the competencies needed to manage value-based payment, as well as the ability to negotiate contract terms by being first to market. Employers are interested in alternate strategies that help reduce their healthcare costs. Bundle payments give payers and employers the necessary flexibility to redirect patients to high-quality providers, or center of excellence models, as I mentioned before, by changing benefits in ways that lowers the patient's out-of-pocket cost. And lastly, consumers are becoming better educated and seeking high-quality providers. Bundle payments force providers to look at their quality data and practice patterns to identify where there are opportunities to reduce variation and improve care for patients throughout the entire care continuum, outside the traditional four walls of the hospital. Moving to slide 9, commercial bundle payments across the country. As I mentioned, commercial bundle payments are gaining momentum. We see commercial bundle payments across the country in both large and small markets. Joint replacement remains a popular procedure to bundle, and typically we see joint replacements as a first step that both payers and providers take when starting their bundle payment programs. And then if they're successful with the joint replacement bundles, they then expand to other types of bundles, such as other orthopedic episodes or branching into maternity or other more chronic episodes. On slide 10, although specific details of many of these payer-provider bundle payment arrangements are kept confidential, comprehensive agreements include the key components shown on this slide. Once the bundle is triggered, what is the length of time for costs associated with the episode? For example, does it start with hospital admission, or is there a look-back period, such as 3 days prior to the hospital admission? What period post-discharge will be included? Will it be 30, 60, or 90 days? What is the baseline period? What historical pricing will the payer use to determine the target price, or what has the provider used to propose their price? How will the provider be paid? Will it be a retrospective or a prospective arrangement? Will all providers be paid per usual with a reconciliation at the end of a performance year? Will it be prospective? If so, does the provider receive a lump sum and is responsible for paying all other downstream providers? And then who will be responsible for adjudicating those claims under either model? What sites trigger an episode the provider will be responsible for? Will it only be for those episodes triggered at their inpatient facility? Or if the bundle is with a physician group, will it only be triggered at certain facilities? Ken will get more on this later in the presentation, but will the provider take a discount on historical payment? If so, is there anything they get in return, such as guaranteed volume or exclusivity terms? And then how will savings ultimately be calculated? Typically, it's defined as target expenditures minus actual, but are there any provisions that we want to put in place, such as a savings or losses up to a predetermined amount? Again, since these are commercial arrangements, there is room to negotiate and customize for your organization, unlike a government bundle where all parameters have been predetermined. Over the next couple of slides, we have information on bundle payment programs we've seen in the market. Starting on slide 11, in 2018, United Healthcare expanded its bundle payment program to include 37 markets, covering 46 facilities and 3 million employees. And this program covers total hip and knee, discectomy, lumbar spinal fusion, and maternity. So United started with the more defined orthopedic episodes, and as you can see on the right-hand part of the slide, they're planning to add more chronic and less episodic episodes like cardiac in 2020. This program has been successful for them. The program has reduced hospital readmissions by 22% for joint replacement surgeries and 10% for spine surgeries. and it's generated nearly $18 million in total savings, with an average savings of $18,000 per surgery for participating employers. So again, this is an example of why employers are flocking to bundle payment arrangements. And then on slide 12, we have an example of a bundled payment program that Premera Blue Cross put into place earlier this year. So last fall, Premera Blue Cross engaged in an RFP process to partner with a provider in Washington State to develop and implement a bundled payment program for joint replacements. Through this RFP process, Premera did define what services needed to be included, but they did leave it up to bidders to determine the pricing and quality metrics. They did allow for some flexibility in terms of the proposals, but as bundled payments gain popularity, we are seeing that more payers are coming to market with defined programs that are more reminiscent of what we're seeing from CMS, which just goes to show that the earlier to market that providers can be, the more negotiating power they'll have when they are entering into these bundled payment arrangements. And with that, I'll now turn the presentation over to Purvi.
Thank you, Rachel. In this section, starting with slide 14, we will plan to cover some of the key factors that can position an organization for success in a commercial bundle payment program. I'm going to start on the top left side of this slide with organizational alignment. The bundle payment program that you choose to pursue should align with your organizational service line strategy and payer strategy. Having this alignment will also facilitate buy-in from your leadership team and other key stakeholders, which is really fundamental in driving the process forward. Now, one of those key stakeholder groups will be your physicians, and we believe that a comprehensive, well-executed physician engagement strategy with physician champions is critical to driving success. And the development and implementation of an effective gain-sharing model with physicians will also help align financial incentives. The physicians will also be key in driving some of the initiatives related to care standardization. We've seen many situations where reductions in clinical variation does produce better outcomes at a lower cost. And then standardizing care across the care continuum is also important. So post-acute care management through care coordination and care transition processes should be developed, and they should be done so in partnership with select post-acute providers. And then moving on to the bottom left, I would say that analytic capabilities are essential to a commercial bundle program, not only for establishing pricing, but also for evaluating opportunities for performance improvement and helping to determine which opportunities have the biggest strategic, financial, and operational impact on your program performance. And finally, you want to set up a structure for oversight and monitoring that will allow you to manage and sustain the bundle payment success. Now, we'll dive into each of these, starting with slide 15. As we previously mentioned, one of the fundamental criteria before pursuing a bundle payment program is organizational support and buy-in from leadership. Bundle payments are certainly on the path towards value-based transformation, which really hinges on the convergence of both financial and strategic capabilities and performance. So we've laid out here the key financial and strategic considerations that we often evaluate when developing a bundle payment strategy. From a strategic perspective, your bundle payment program should align with your service line strategy and organizational strengths. And the physicians within that service line are also key to determining success. You should have an apparent physician champion who is willing to take the reins, push this initiative forward, and establish greater accountability from other providers. And in order to do so, there should also be an opportunity for bi-directional communication, where physicians are not only aware of your strategic priorities, program requirements, and ongoing performance, but that they also have a vehicle through which they can ask questions and provide feedback regarding barriers to implementation or suggestions for change. Then market dynamics are also a key strategic indicator and may already be driving your overall service line strategy. The provider and payer landscape may impact some of the key terms in your bundle payment arrangement, such as exclusivity or market share, as Rachel had mentioned. Or your strategy may be dependent on whether other health systems, hospitals, or physician groups already have a bundle payment arrangement in place with payers or employers. And finally, quality is also a key consideration. There must be a culture of continuous quality improvement in order to make this value-based model work. Quality performance impacts financial performance, and while it may not be optimal in your current state, you do want to make sure that there are processes that can be implemented to drive improvement. And then on the financial side, the key considerations are volume, which you want to make sure is sufficient enough to protect against variability, historical episode spending and how that reconciles against potential target prices and potential margins, and post-acute care utilization. Again, the post-acute environment presents one of the greatest opportunities for savings. And if you see a high proportion of spending for a given episode is in the post-acute environment, we believe that it could be a viable episode that presents financial opportunity. But that certainly would need to be weighted against some of these other factors. Moving on to slide 16. We've talked about how physician engagement is paramount to bundle payment success, but we should talk about what it really means to be an engaged provider. In our experience, engaged providers are accountable, collaborative, informed regarding program details, and communicative. Now, a physician champion can help drive engagement, so we should also define the key attributes of a physician champion. In our experience, a physician champion is somebody who is willing to act as a liaison between administration and other providers, someone who serves as a point of contact for other providers, someone who encourages participation amongst providers, and someone who's also willing to help educate other providers as needed regarding the program components and requirements. On slide 17, we want to talk about how the development and implementation of an effective gain-sharing model can also further engage physicians and align financial incentives. The context in which we use gain-sharing here is consistent with the OIG definition, where physicians have an opportunity to share in the savings earned based on reduction of spending or costs incurred for patient care. There is no specific legal structure for a gain-sharing agreement, except that we do advise that the payments to physicians should be conditioned upon quality and performance criteria. Now, a typical gain-sharing arrangement or agreement often includes an overall description of how savings will be split across the relevant parties and how funds or savings will flow through the organization, with details such as key contingencies and performance thresholds. It should also clearly define the performance expectations or performance metrics to which the physicians will be held accountable and will drive their own financial opportunity. We found that the most effective metrics to include in a gain-sharing agreement are those that the physician is able to impact and whose performance will also drive overall success in the program. Moving on to slide 18. Once you have engagement, the physicians will be key in driving care standardization or clinical redesign efforts. We believe the best place to start is with a care process map. Many organizations may already have these, but it's always advisable to revisit the care process map with all key stakeholders, who are often multidisciplinary, and having them all in one room to discuss and understand each component of the episode, from the acute hospitalization or outpatient service through the post-acute continuum. And during this discussion, you'll be able to clarify roles and responsibilities and even identify bottlenecks in patient flow. And as you're talking about current state, you'll inevitably be able to identify new processes or changes needed for an ideal future state. Once your care process map is complete, you'll want to develop or revisit clinical pathways and order sets to ensure that they're aligned with the care process map. They should also incorporate risk factor protocols to ensure that patients are treated based on their level of complexity and risk to avoid future setbacks such as readmissions. And finally, patient engagement and experience are an integral part of care management and key to driving favorable outcomes. You want to make sure that you have processes and resources in place to empower patients and their families to become active participants in their care and engage patients before admission if possible, and after discharge to help guide, educate, and monitor their recovery. And with a commercial bundle, you can often partner with the commercial payer to help provide some of these resources. On slide 19, I wanted to provide a quick example of a care process map that was developed for a STEMI episode. You'll see that the care process map starts from various potential entry points on the left-hand side for the patient, including the cardiac cath lab or direct admission. It also identifies where in the hospital the patient may be located, as well as who is involved in their care. And to the points we made earlier on the previous slide, we've also highlighted in yellow the points in which the order sets are initiated. In blue boxes, we've identified future state activities that were identified as necessary to incorporate into the process. And then even small red GPS indicators are embedded in the process map to emphasize potential opportunities for patient-family touch points in order to provide and reinforce expectations of care and education. Let's move to slide 20 now. Value-based payment models such as bundle payments really focus on improving patient outcomes and experience by coordinating and streamlining the entire continuum of care, which includes post-acute environment. Therefore, the implementation of a post-acute strategy is critical to driving cost reduction and improved outcomes. And we believe there are three primary components to a post-acute strategy. The first is the post-acute network, which entails a targeted group of post-acute providers that you can partner and collaborate with to establish standards of care and manage patient outcomes. Who you select to be in your preferred network of post-acute providers can be based on a variety of factors, including historical utilization patterns, geography, quality of care, staffing models, and perhaps even physician relationships. And establishing a post-acute provider network will help you better manage your bundle payment patients through increased coordination, collaboration, and data sharing. Now, through the partnerships, efforts should also focus on ensuring effective care transitions. Now, this would involve developing admission and transition criteria or discharge placement guidelines in collaboration with your post-acute providers if possible. And finally, a strong transitional care program and strategy often includes care navigators who provide both patient education and care coordination. This role and their processes should be reflected in the care process mapping as well and should be involved in other care redesign efforts. Particularly important is going to be timing of those post-acute touchpoints by the care navigators and scripting to include targeted questions and appropriate triaging based on those patient responses. Now, moving on to slide 21. We've covered a lot of ground in terms of establishing an effective bundle payment program and the processes that you need to position your organization for success. But this should be a long-term and sustainable strategy. So you need an effective framework, such as the example here, that considers dividing program responsibilities, coordinating among functional areas, and assuring accountability. We have the work streams on the bottom of this slide in blue boxes, and they are based on key functional areas which align with some of the success factors that we've talked about. And each of the work streams we believe should include multidisciplinary stakeholders and should be led by a clinical representative and an administrative representative. The clinical lead can help ensure physician buy-in and alignment, and the administrative lead can focus on managing the resources needed to operationalize some of the targeted efforts. And while each workstream may have its own objectives and responsibilities, we have seen that significant overlap can exist, so coordination and collaboration amongst these groups is essential. And as we've mentioned before, leadership support from all levels of the organization is vital to program success. So each of these work streams reports up to a bundle payment steering committee, which is accountable then to a board of directors. The bundle payment steering committee is typically comprised of C-suite executives and key decision makers who can help support and guide resource allocation and provide oversight to the work groups to ensure that their efforts are aligned. And then hospital compliance also has a role in providing guidance on gain sharing agreements and even contracts with post-acute care providers and even with your commercial payers. We've found this framework to be scalable and can be applied as an organization's bundle payment strategy extends across clinical episodes, across service lines, and even across a healthcare system with participation from multiple hospitals. Now, the last box on the bottom of this slide is the quality data and IT work stream, which is one of the success factors that we have not yet discussed. So I'm now going to let my colleague Rachel talk you through some of the key analytic capabilities needed for a commercial bundle.
Thank you. Starting with slide 23, as Purvi mentioned, comprehensive analytic capabilities are critical to implementing a successful bundle. It is imperative that organizations understand both their baseline performance and pricing. There are four main components that we look at when preparing organizations for commercial bundles. The first is utilization. We look at the volume or utilization associated with each category to understand what services the organization has historically provided. The second is pricing. We calculate the expected payment, the charges, revenue, fixed cost, variable cost, and margins associated with the episode to understand the impact of entering into a fixed price. Third, we look at variation across physicians and quality performance to determine if there are any additional improvement opportunities to optimize bundle performance. And fourth, we look at year-over-year trends and compare payers to determine where there is the most market opportunity. Moving to slide 24, when pricing a bundle, we typically break the analysis into three phases and look at historical claims associated with the following: Preoperative care, we group claims related to pre-op visits, including primary care, surgeon visits, imaging, and lab. For acute or for the anchor episode, we group claims related to the hospital or outpatient services, surgeon or other physician reimbursement, anesthesia, and implants. And then for post-acute care, we group claims related to post-op visits, like a follow-up visit with a surgeon, physical therapy, imaging, lab, and then any other post-acute services like home health. We work closely with clinical teams to review the claims found in each phase to determine if they are a routine service and should be included in the bundle. We then cross-reference industry resources and then further refine based on our client's experience. We also spend time determining exclusions and building a case why they should be excluded based on clinical guidelines. And we find that understanding the utilization and pricing, such as the expected versus margin, we begin to piece together the bundle payment price, and we'll show you an example of the output in the next couple of slides. On slide 25, we have an example of a pricing comparison utilizing Medicare fee-for-service claims data. This type of analysis, where we compare a client to benchmarks, can help determine what the value proposition might be and have implications on the pricing model. Even though this example is for the Medicare fee-for-service population, we include assumptions and validate with the client around skilled nursing utilization and how reducing that historical amount can either produce a better bundled payment price, which in turn is more attractive to the payer, or even if we base the bundle price on historical experience, we now know where there is an area of opportunity to reduce spend under a bundled arrangement. On slide 26, we have an example of physician comparison. Again, utilizing Medicare fee-for-service claims data, we use this type of analysis to understand where there may be additional opportunities for improvement under a bundle. For example, even if the bundle is based on historical performance, we can see that there is variation between physicians. If we look at physician 2 in that second column from the left, with their 41 cases, they're discharging to skilled nursing 60% of the time. However, looking at physician 6, third from the right, with 54 cases, we see that they're discharging 15% of their patients to skilled nursing. In our experience, sharing this type of unblinded physician data tends to spark conversations around best practices and really drives behavior change. Therefore, if an organization is able to work with its physicians, either through a gain-sharing agreement or just through any sort of care redesign activities to reduce any unnecessary utilization or testing, we see that that organization then tends to perform better under a bundle because they've truly reduced a lot of variation around care patterns. And then lastly, on slide 27, we have an example of our pricing analytics. On this slide, we are looking at an exhibit that outlines the sample pricing for MSG 470, which is a lower extremity joint replacement without complications based on 12 months of claims. As mentioned previously, we segment the pricing by phase, so grouping together claims that fall into the pre-op phase, that acute or anchor phase if it's for an outpatient episode, and then the post-op phase. We worked with this client to define that pre-op phase as 3 months prior to surgery, and that it would include the orthopedic surgeon visit, medical clearance from both a primary care physician and a cardiologist, physical therapy, radiology, and lab. Again, we used industry guidelines and then worked with our client to further determine which services should be included. Then the acute phase included the hospital stay, the orthopedic surgeon, hospitalist, and anesthesia. Once we've come to a consensus on what services we want included in the bundle, we then dig into an organization's claims data to determine that average expected payment. And then in cases where we don't have claims data, for example, if independent physicians are involved, then we make assumptions using industry sources to approximate that average expected payment. And then the post-op phase included a follow-up visit with an orthopedic surgeon, primary care, physical therapy, and radiology that happened within 90 days after discharge. And again, when developing a bundle to present to a payer or an employer, we work with our clients to determine which services and for what time period they want to hold risk for. We've worked with clients on multiple bundles, and this has ranged from a 30-day joint bundle to a 12-month bariatric bundle. And then once we've calculated that baseline price, we then work with our clients on a pricing strategy, which Ken will cover on the next couple of slides. So I'll now turn the presentation back over to Ken.
Thank you, Rachel. Before we talk about payer and employer negotiations on slide 29, I just want to remind everybody that there's an opportunity to ask questions, so please send those questions in electronically because we have reserved some time at the end of the presentation to answer your questions. So on slide 29, when you talk about payers and employers, what's the approach? If you've developed a commercial bundle, you want to be able to go out and talk to those payers and employers about a number of different things. So here are some of the key components. One is what's the target in your market? Are there large commercial payers that you would like to approach? Are there employers? Are there self-funded employers out there? Are there unions? So think about where you might have the most success in your market and who those organizations are. The second thing is the value proposition. We're going to talk about a pitch deck in just a minute, but what do you as a hospital or as a physician organization bring to an employer or a payer in terms of adding value? And they're obviously looking at improved quality and a reduction in their spend. Third thing is the program parameters, and Rachel covered that in terms of the different components. What happens prior to an episode, what happens during the episode, either the surgery or the admission to the hospital, and then what happens post-discharge. And then a pricing strategy. Don't suggest that you go in with a price, but you need to be able to articulate kind of how you're approaching pricing, how you're going to add value, because that's certainly going to be the first thing that the payers and the employer are going to want to know is what's your pricing strategy. And then number 5 here, there's still going to be some claims adjudication. Someone's going to have to send claims someplace, even though there may be a bundle payment price going to a certain entity. You still want to keep track of what's the fee-for-service volume, what have been the fee-for-service spend, and compare that to the bundle payment price. So you have to figure out the claims adjudication process. And then lastly, you want to finalize the agreement. So on slide 30, again, we call it the pitch deck, but this is your opportunity to showcase your organization with a payer or an employer in terms of the value add. So on the left-hand side here, what should be included, an overview of your program, whether that's orthopedics or cardiac or bariatrics, who are the doctors that would be part of the bundled payment, where are their offices, what services do they provide. You want to make sure that you can talk to the latest surgical techniques and state-of-the-art equipment so they can showcase your services. On the right-hand side here, probably the two most important things in terms of adding value is care coordination and care navigation services. Because again, in a commercial environment, there's handoffs from setting to setting, but no one's really managing the continuum of care. So in a bundled payment approach, you're going to be able to manage that continuum of care and add value. Part of that is the care coordination. And what we're seeing on the commercial side is obviously reduction in the ER usage and also a reduction in readmissions. And that reduces an employer's or commercial payer's costs. On slide 31, suggest you have kind of a philosophical discussion around pricing, because there's lots of different things that go into pricing before you start looking at data. A couple things here that we want to mention. One is there additional volume available in the marketplace? And if so, do you think you could capture that volume through a bundle payment program? And then could you capture market share beyond your primary service area? So organizations are looking at bundles as an opportunity to have a larger geographical reach and to gain market share. And then what's the volume worth? Payers are going to expect some kind of a discount. So a high volume payer is probably going to expect a more substantial discount than a low volume payer. And we'll talk about pricing and tiering here in just a moment. And then what's your maximum discount level? So we know a lot of payers like to think about a 20% reduction kind of off their commercial fee-for-service spend. We know that providers oftentimes are thinking of a range of anywhere from 0 to 5%, and we'll talk about why 0 as an example. And then should you expect volume increases? Can that payer really redirect volume to your bundle payment program? The best way to do that is through health benefit redesign and centers of excellence, and then pricing tiers. The more volume, as an example, more additional volume, you can afford additional discounts. So on slide 32, this is just a way of thinking about different pricing ranges. So on the left-hand side, we have a payer discount of 3 to 5% for a bundle, 6 to 9%, and 10 to 15%. So if you're looking at a 3 to 5% discount, it's a low financial risk for an organization, but also provides you with an opportunity to align your physician strategy, because you can do gain sharing, as Purvi pointed out previously. But probably no volume guarantees, I don't think you need to ask for them, because you're really just trying to understand how bundle payments work and get your organization more into the value-based arena. 6 to 9%, you're going to be taking on some more financial risk. There's more physician alignment opportunity because you want the doctors to be organized around bundle payments and reducing the spend. And again, at that level, you might want to ask for volume increases or have some contingencies around volume increases. If you get to a 10 to 15% discount for a bundle payment versus what you're receiving fee for service, again, higher risk, and we like to have those arrangements contingent upon some kind of additional volume guarantees. So some different ways to think about pricing for your organization. So on 33, we want to talk about a case study. One of our clients, an ambulatory surgery center owned by physicians, that was competing and looking at a partial knee replacement. And part of this is at the top of this page. Ideally, you want to have, when you're looking at bundle payment pricing, you want to have revenue information. What are you getting paid today in terms of fee for service? What are those services actually costing you to deliver? And what's your kind of expected profit margin? But organizations don't always have all those components. So you have to make do with what you have, and you have to do some projections. The second approach is looking at what you're getting paid and trying to understand what your competitors in the marketplace might be getting paid. And that's the example we have here. So if we look at the analysis section in the middle of this slide, we looked at this partial knee replacement from a hospital outpatient department or hospital ASC perspective versus a physician-owned freestanding, and there's great differences in terms of the Medicare fee schedule. So we started with the Medicare rate, and for hospital outpatient department, they would receive $11,029. We think that marketplace, they were receiving about 200% of the Medicare rate for the commercial patients, so they were getting paid $22,057 from the payer, and that's again kind of projected based upon our understanding of the marketplace. For the ambulatory surgery center, their Medicare base rate is much lower, $7,983. Market rates are about 160% of 160% of Medicare for commercial, so a $12,000 spend. So in this case, the ASC could actually increase their current rates above what they're getting paid today, because as long as they didn't get to the $22,057 of their hospital competitors, they would still be saving the health plan or the employer dollars in terms of a lower spend if they redirect volume away from the hospital. And we're starting to see now nationally a lot of interest around moving volume out of the hospital into these ambulatory surgery center sites. So on 34, again, another pricing approach. With pricing, again, you have to be creative in how you approach this depending upon the data that you have, not only your own data, but maybe you'll have some market data that's blinded, and we'll have an example of that in just a moment. So in this case, this was a total hip and knee replacement for a commercial bundle, and it was with one payer, but we looked at multiple data sets here to figure out where is the starting point. So option 3 here is what we kind of chose as the benchmark to kind of negotiate from there. And we looked at here was for the payer that we were negotiating with, what's the volume in 2017? What are the number of episodes, and what was the fee-for-service spend? So there are 47 episodes, and they spent $36,000 for those services. Above that, we looked at the entire commercial population at that organization for total hips and knees, 657 cases, and a price of $42,458. Decided that was not the best data point. And then on option 4, we looked at 3 years worth of data for the same payer, 271 cases, $35,464, which is very close to their most recent experience in 2017. But you have to use whatever data you have to come up with some kind of a baseline or rationale for starting a pricing discussion and pricing your bundle. So on slide 35, a little bit more sophisticated example, because we had ECG, the payer information for DRG 470, the preoperative side, the anchor, and also the postoperative. So for payer XYZ, we know that the preoperative spend was $437, which is the subtotal. The anchor spend was $43,577. And we also knew the postoperative spend, which is $1,827. So for that bundle payment, that payer had been paying all those services on a fee-for-service basis, $45,841. We also knew that this organization had a hefty, nice profit margin of 66%. So we benchmarked against benchmark A, again, with some third-party data that shows what other organizations blindedly were receiving in the marketplace. But if you go down here to the total line under benchmark A, other providers were being paid $30,164 on a fee-for-service basis for the services that we wanted to bundle on behalf of the client. And then we did another benchmark over here, the second column from the right, a benchmark B, where that benchmark showed that rates were 35,000. So the dilemma here was that for this organization, their current fee-for-service revenue was 45,841. Their competitor market, based upon benchmark A and benchmark B, were 52% and 30% below their current rates. So they were in a difficult spot in terms of developing a bundle to add value, because they were going to have to discount their rates substantially to be more competitive with the marketplace. So again, another opportunity to look at data and help you decide what your pricing approach should be. So with that, I'd like to have Purvi start to talk about key takeaways.
All right, thank you, Ken. So we've provided you all with a detailed review of the key steps and components needed to develop and support a commercial bundle payment program. And while it may seem relatively straightforward when laid out on paper, there certainly may be roadblocks or implementation challenges that you face along the way. So on slide 37, we've actually identified the top 5 challenges that we've seen providers encounter when they're implementing a commercial bundle. Now, pricing a commercial bundle may require not only some creativity, but also a comprehensive set of claims that reflect the full continuum of care during an episode, especially if you're including professional and post-acute services, which can be very challenging for a provider to obtain in some instances. And this is where collaboration and transparency are key in your provider partnership, since the payer may need to be the ones that provide the complete set of claims. And if this still presents a challenge, industry associations and benchmarks can often be a resource for payment and cost, as Ken had described earlier. And even if you do receive a comprehensive claim set, it may be difficult to identify and track a unique patient across the entire continuum. So you want to make sure all of this is discussed prior to the claims data being pulled, because there can be various strategies that can be used to digitally flag a patient across care settings and be able to track their complete episode. Now, the process used to adjudicate claims in a bundle payment arrangement can also vary, as Ken mentioned, and can be complex when you're dealing with a variety of different providers. And this will be largely dependent on the payer's capabilities and may sometimes fall on the lap of the providers. So you want to be sure that this is also discussed up front so that you can build the competencies needed to be able to adjudicate claims if you do fall into that situation. And then we talked a lot up front about provider engagement driving success. We have found that, again, a physician champion is really key to driving engagement because they can have peer-to-peer discussions and they may even have greater access to other physicians. And then finally, once your program is up and running, you want to make sure that there is a process in place for monitoring performance and ensuring compliance with key terms of the arrangement. The framework that we had laid out previously can really help facilitate this, since you will have oversight from leadership, participation from compliance, and even a work group charged with developing performance dashboard with real-time data. Moving on to slide 38. We do believe that a commercial bundle payment arrangement can offer an immediate opportunity to participate in a value-based model and can really help organizations move further along the continuum of risk-based payment models that focus on care management and care coordination. There are significant advantages to pursuing a bundle payment strategy, particularly in the commercial environment, including market share growth, enhancing your service strategy and alignment, facilitating physician engagement and alignment, having limited financial risk, and the ability to develop new organizational competencies and capabilities that can further your transition and success in a value-based environment. And now I'm going to turn it back over to Ken, who will help moderate the question and answer session.
Thank you, Purvi. Before we move on to some of the questions, just a reminder that you can continue to enter questions in the question pane. We'll ask as many questions as we can on your behalf as time permits. So first question, how would a payer and or provider capture additional volume via use of bundle payments? Is this through marketing, payers directing patients to those providers? So volume, market share, great question. So from a payer perspective, I think payers are trying to add value. And one of the ways that they add value is putting in a bundle payment program, because it does tend to reduce costs. It does tend to reduce ER visits and readmissions. So from a payer perspective, they might look at this as an opportunity to be more competitive than other payers in the marketplace. From an employer, it's kind of the same thing. How can we reduce our spend and improve our quality? And these bundle payment programs are designed for that. If you're a provider that has a bundle payment that you've designed, what we've seen is the best way to attract additional volume is to work with those employers or health plans to change the benefit design, to create an incentive to use your center of excellence or your bundle payment program. So if there's a lower out-of-pocket cost, co-pays, co-insurance, deductibles, what we find is that really motivates people, particularly for elective procedures that they can go elsewhere and they can shop around for. Once you change that benefit design, that's really the game changer. I'll ask my colleagues, Purvi and Rachel, if they have any more comments around gaining additional volume through bundle payment arrangements.
No, I don't have anything additional.
Okay, very good. So next question here, with Optum's purchase of ASCs, are you seeing UnitedHealthcare carve out some services and driving them to their own practices? I can't say I've seen examples of that, but I think that's a natural next step. If you're gonna buy an ASC in a marketplace, they're both UnitedHealthcare is both a health plan and also providing services, and they're looking at reducing their spend. So I would assume over time that as they acquire assets, and that would be any health plan, if they can provide those services in a lower cost environment, they'll probably direct that volume to that location. Purvi or Rachel, anything you'd like to add to that? Anything you've seen around Optum and their purchase of ASCs?
I would agree with what you said and just add on that with bundled payment arrangements, we really do see both payers and providers really tightening the network and trying to make sure that their patients are going to thoroughly vetted providers so that they understand the spend and it's not a huge surprise.
Thank you, Rachel. Next question: Are there criteria for patients? Are the criteria for which patients are eligible for the bundle established in the contract? How is that typically addressed? Yeah, this has actually become kind of simplified in terms of who qualifies for a bundled payment. So as long as you have that episode of care, whether you have cardiac surgery or hip or knee replacement or a sepsis incident, that is the qualifier, that the services are provided. And so once you have those services, and if there's an arrangement with a payer that hips and knees are in a bundled payment or a cardiac procedure is a bundled payment, by definition that you had the services at the location or with the group that is contracted to provide bundled payments, then you're in. So there's no, it's I would say automatic in terms of how that works. Purvi or Rachel, go ahead.
Sure. I would also add that this is where exclusion criteria are also key. So while a patient may trigger an episode with a certain DRG or a CPT code, for example, you do want to look at some of their other comorbid conditions to ensure that it is an appropriate patient for that episode. And even further down the road through the care continuum, there aren't other extenuating circumstances that might push them out of the episode or qualifying for the episode.
And I would also just add that this is why we're seeing a lot of employers using those center of excellence models, because they trust those providers to perform appropriate surgeries and that there's often alternative care pathways for those patients who might not be the best candidates for surgery.
So the questions are flying in. Thank you. Keep them coming. Next one. When building out a price for any commercial bundle, should it not include some expected use rate of SNF or IRF, which is rehab? So a terrific question, because this is the dialogue that we're having with our clients around the country. So this really depends upon your perspective as a provider. How much risk do you want to take? So in some commercial bundles, we've seen the health plans say you're taking risk for the 90 days after, and that includes ER visits, and that includes SNFs, and that includes rehab. So that model does exist out there. I would say most providers don't want to take on in the commercial environment, and a lot of commercial patients don't need SNF or rehab, depends upon the services, but since they're a younger population. But most providers are reluctant to take on SNF or rehab utilization. They'll take, in terms of that 90 days, that 30 days post-procedure, post-acute care, but they will take risk for professional services, for lab and for imaging, kind of typical follow-up. But you know, as a health plan, you can expect and outline the risk that you want payers to take, and part of that is probably negotiated. And we've seen it both ways. Purvi or Rachel, do you want to comment on SNF or rehab in terms of pricing for a commercial bundle?
I would only add that it is somewhat dependent also on whether you're talking about a medical episode or a surgical episode. I think there's some variability there in terms of how much post-acute utilization may be required.
Okay. Next question, a good kind of technical question, but important. For gain sharing with physicians under commercial bundles, is a specific waiver from OIG required, as there was an order to gain share under BPCI? So I think the short answer to that is no. We're not aware that there's a waiver for commercial bundles, but Rachel and Purvi, you're a little bit closer to this than me, but what else can you add in terms of commercial bundles and an OIG waiver? I haven't seen it, but did your opinion differ?
I have not seen it either, but again, I think the best protection for you in that instance is, again, making sure that some of that gain sharing is contingent upon the physicians meeting certain performance criteria and establishing very specific and defined quality metrics that the physicians are held accountable to in order to earn that gain sharing payment.
Okay, very good. Here's a question. How much would you add or percentage into the total price to help mitigate the downside risk of the episode? So part of this, in terms of the downside, so if your expenses or your spend for that bundle payment exceed whatever that price is, say it's a $10,000 price, and you end up paying $12,000 for those services, kind of on a fee-for-service basis, because you may not have all those services. So what we typically do is estimate utilization in terms of the best way to mitigate risk, in our opinion, is to estimate utilization kind of from high to low in terms of the things that you can't necessarily control, like a SNF utilization, like rehab. And then a lot of organizations will add a factor in there in terms of let's add a few more dollars because a lot of these models, we don't have great data on commercial bundles yet. It's evolving, it's getting better, but that is a big concern of a lot of organizations is how much risk are we taking? Therefore, in order to cover that risk, we've got to increase our prices on the bundle payment. And so as payers say, take more and more responsibility for that 30, 60, 90 days all in on SNF and rehab, you've got to increase your prices in order to cover for that risk. And right now the risk really varies. And I think what you're going to see is not really a fudge factor, but a risk factor being added as a percentage. And I think if you wanted a percentage, I'd say 10 to 15%. I think that would be reasonable to add to your pricing in order to absorb some of that risk where you just can't control or predict the services. So Rachel or Purvi, do you want to comment on that? Because it is all about risk. And how do you mitigate that risk? But you do have to, I think, increase your prices because of that unpredictability. Okay, here's a good question, very forward-thinking here. How should industry-sponsored clinical trials map to a bundle payment program? So I would say that describes a very sophisticated market, and where clinical trials are either going to inform a bundle payment decision, could inform pricing, but I don't think they're quite connected yet because I think clinical trials kind of in their own space, bundle payments kind of in their own space, but I think over time they will inform each other. And whether you can go out based upon because the clinical trials, I'm not in academic healthcare, we do have a whole group of people at ECG that does this kind of work, but I'm assuming that clinical trials to get to market, may take some time. And so as clinical trials evolve and medicine delivery changes, then I think that may inform bundle payment decisions because that may increase or decrease the cost of care. So I would see that playing out that way, but I think right now this is a good question to kind of watch to see how it evolves. But I don't think right now they'll impact each other. Okay, so I think we're at the end of our session here, so I do want to wrap this up. I wanted to thank you for your attendance today. ECG really appreciates your time and effort. Obviously, there's a lot of interest in bundled payments out there. As a reminder, send in your responses in order for $5 to go to Doctors Without Borders. I really appreciate that. You can tell I've lost my scripts as I'm mumbling here. But I just want to say thank you to everybody. It's been a great session. Hopefully you've learned something today. And if there's any follow-up questions, please feel free to answer or contact any of us. Thank you very much. Bye-bye.